Next, we have Dr. Megan Waldrop, who is a pediatric neurologist at Nationwide Children's Hospital and an assistant professor of pediatrics and neurology at The Ohio State University College of Medicine. She completed her pediatrics and child neurology training at the Children's Hospital of Orange County, University of California, Irvine School of Medicine. She completed a neuromuscular medicine fellowship at The Ohio State University and at Nationwide Children's Hospital, and a neuromuscular genetics therapeutics fellowship at Nationwide Children's Hospital. She is board certified in neuromuscular medicine and neurology with special qualifications in child neurology. Her clinical and research interests include muscular dystrophy, congenital myopathy, SMA, with particular interest in the diagnosis and treatment of rare neuromuscular diseases. So thank you very much for being here this Saturday. You can go ahead and share us your screen and start your presentation.
All right. Hi, everyone. It's great to be here, and I'd like to thank the MDA for inviting me to give this talk. I am going to try and share my screen. Hopefully this will work. Is this working?
Yes.
All right. Okay, so I'm going to talk today about what are the kind of immediate next steps after your child's been diagnosed with a neuromuscular disease. I do want to say that this is by no means exhaustive, and of course, for every patient, there might be some unique challenges, and so not everything can be applicable to everyone with the same diagnosis. But I think these are good kind of jumping off points and things to think about as you move forward on your journey with this new diagnosis. So first, I'm going to start with just general recommendations for almost any sort of neuromuscular condition. I will say that I'm focusing more on inherited conditions today, but there probably is the ability to extrapolate what I am talking about to more of the acquired conditions, but really the focus is going to be on those that are inherited. So first, I wanted to start with the understanding that this is kind of like a loss. And so it does really make sense that everyone is going to go through what we know of kind of the grief cycle. And so KÜBLER-ROSS has defined this and defined the stages. There are some variations out there, but the general concept is the same. Usually, initially, there is some sort of denial. There can be a lot of fear or anger. This is all normal, and it's totally expected whenever you get some sort of big diagnosis in your life, and that does include neuromuscular disease. And you can move on to frustration or anxiety, and then there might be some bargaining, struggling to find meaning with life, being very kind of at a low point is how we tend to think about it, just meaning you don't feel like there's any hope. Eventually, that will then kind of turn into maybe some sadness. Unfortunately, I see a lot of family members who experience a lot of guilt. I think that's a common stigma with inherited conditions because usually it's related to some sort of genetic change in the parent. However, that's not always the case. But regardless, we always like to stress that this is in no way caused by the parents. It's just an unfortunate occurrence that happened, and it's nothing to feel guilty about. And eventually, everyone will move on to some form of acceptance, meaning how do we move forward from this? You know, what are we going to do? And just kind of moving on with this new diagnosis and this big change in your life. So my first recommendation for everyone is to find a good pediatrician or medical home. And I say medical home because it could be a family practice doctor. Sometimes those actually take care of the whole family, and so that's a better fit. In an ideal world, I think most of our patients would love for us as the neuromuscular and kind of MDA clinic to be able to be totally comprehensive, meaning the pediatrician visit is there, any sort of concern that you have, we can address. And we would love to do that, but unfortunately there are not enough of us in the world, and we are usually struggling to give adequate care with just the subspecialties we have in the MDA clinic, and we just can't take on the general pediatrician or general family doc role as well. And it's really important because I always like to say your child is a child first. So they're going to have a lot of stuff that just, every child in the world has. So they may get an ear infection. They may get lots of ear infections. They may have a cold. They may have a skin rash, things that are pretty unrelated to neuromuscular disease. So it's very nice to have a pediatrician that you can trust or a family doc that you can trust that can help you through these things. Additionally, in all of our children, we are big proponents of vaccination. We think it's important to prevent any disease that we can, because we know in children with neuromuscular disease, if you do get a serious infection, you're going to be a lot more affected than somebody who does not have a neuromuscular disease. Also, basic preventative care is very important to get done. And then, maybe when your kid's just being a kid, they might have an unexpected cut or broken bone. And so it's, again, very important to have somebody that's located close to you and that you have a good relationship with to kind of take care of some of those basic needs. However, sometimes our patients and or parents are very concerned that the pediatrician or the family doctor just does not understand neuromuscular disease. And that's possible. These are times we are dealing with pediatricians who've never had a patient with this condition before. But I will say that the vast majority that I've interacted with are very eager to learn, and we communicate fairly regularly, and they're a great resource for us. And we can communicate together whenever the child has a need to kind of get everything taken care of quickly. And so I would hope that you are all able to find a pediatrician or family doctor that is a good fit for you, and then also find a pediatric neurologist or a neuromuscular specialist who's very willing to communicate and kind of become part of your medical team. And I also bring this up, I do think that most families realize this, but there's always somebody who struggles to realize that the diagnosis affects the parents. The diagnosis affects the siblings, maybe affects the cousins, maybe affects the extended family. And so this is really something that affects the whole family, and it needs to be addressed in a way that can help everyone kind of come to terms with this and move forward. And also to realize that everyone is going to deal with this in their own way and in their own time. And it's especially hard for siblings. I think there will be a talk later, but sometimes big accomplishments or exciting times in a sibling's life could be overshadowed by something needing a little more focus or attention in the affected child's life. And so that can be hard. And just realizing the age appropriateness in terms of the child's response and how to help them move forward from that. And then I think it's also very important to remember that it's a family and everyone should have time to enjoy being in the family. So there should be just basic, family time where we don't really talk about the disease or the diagnosis, and just remember that that comes first. I also would like to bring up that it's important to remember that every child has a strength. Anyone who is differently abled also has something that they're probably going to be better at than somebody else. And unfortunately, whenever they usually come to the MDA clinic, we're talking a lot about, well, so what's different than last time? What are you concerned about? What can't you do? What do you need me to help with? And I struggle with this too. I try and do my best to remember at every visit to discuss something that the child has done well, something that the child's excited about, something that they really enjoy doing in their life, just on their own when they're not in school, or if it is school, sometimes they have clubs at school they really like, or projects. So I just want to remember that we should all take time, even the doctors, even when they go to the doctor, to highlight strengths and unique abilities, because it's not fun to always just remember about what you can't do. So we always need to highlight what can be done as well. And then, of course, this is going to be a long, arduous journey for most families. And so you need to have people to help you along the way. This is often family. Sometimes it can also be friends that either have children that are also afflicted with some sort of diagnosis, may not be neuromuscular, or they may not have any knowledge of this at all, but they can still be a great support for you. Of course, the MDA has lots of resources to help anyone find organizations that have for children of the same diagnosis. Sometimes just through clinics, you can find in the waiting room children with similar conditions and start a relationship there. I'm not on social media, but I know that's a big thing now. So also maybe on Facebook or other things that I'm sure I'm not aware of, you can find families that may be great support or friends. A lot of our families also turn to their church groups. I know that's not relevant to everyone, but it is an option. And I do remember when I was early in my training, when I was in medical school, I was seeing a patient in an MDA clinic. And at the end of the visit, the mom of the patient pulled me aside and she said, "I need you moving forward to always tell the parents that they need to focus on their relationship too." She said, "This is very hard and most families will not make it through. And it's very important at the beginning to be very upfront that it's going to be hard. You guys may fight. You're going to need extra support." So I do try and do my best to at least plant the seed that everyone will need some help, but it is sometimes hard to talk about. But I think it's also important for parents, caregivers, to realize that they need time for themselves as well. The way that you can best care for your child is if you're at your optimal self. And the way that we do that, which is hard, is to sometimes step back and take some time for yourself. And so that means that you're going to have to find somebody that you trust to care for your child as well. So you can perhaps have a date night or perhaps have like some spa time or just whatever you need to recharge. So you can always be at the top of your game. And it's okay if you're not, but that's just something to try and think about. And then in general, for anyone with neuromuscular disease, there's a theoretical risk of complication with anesthesia. So I think just the general recommendation, what I have at the bottom of the slide, is that it really would be best if your child needs to undergo anesthesia, that it's done at a center that's comfortable with children, first of all, but also comfortable with neuromuscular disease. Some neuromuscular conditions can have malignant hyperthermia, which is an abnormal response of the body to the anesthesia, where the muscles can get really stiff, they can start to break down, the body temperature can rise very severely. And so it's important to know that this could happen. And so the anesthesiologist knows what medications to avoid, and then also what to closely monitor for. And then just in general, sometimes breathing muscle weakness is a problem, and so there just needs to be extra support once the anesthesia is complete and the child is waking up so that they wake up safely. So now I'm going to move on to some condition-specific recommendations. And again, I'm sorry, this isn't an exhaustive list. I just highlighted a few conditions and we'll talk about some specifics. But again, not exhaustive, and even for each condition, it's not exhaustive, but it's really just a starting off point for if you have a child with this condition. So the first one that we're going to talk about is spinal muscular atrophy. And so this is due to a gene mutation where, because the gene is mutated, the child is unable to make enough of the survival motor neuron protein. And we know that the survival motor neuron protein is important for the health of the motor neuron. And if that motor neuron does not get enough of this protein, it will slowly die over time, which is very unfortunate. This condition, some people refer to it as like pediatric ALS. You know, what it really means is that the vast majority of the time, cognitively, these children are very normal and their body is just failing them. And you can see I put a little picture up in the corner. And so the motor neuron is the part that's in the spine. And then there's this wire-like projection, which is the motor neuron coming down and making a connection with the muscle fiber. And as that motor neuron, that little wire-like projection, as it comes down, as it gets injured, the connection with the muscle fiber gets less and less strong and eventually goes away. And if there's no connection to the muscle fiber, that muscle fiber is going to die, and then that child will have weakness and won't be able to move that muscle. But what's really great is that we actually now have treatments that can really significantly change the course of this disease. So what's important, though, is that it's time sensitive. And so you kind of need to be a little bit proactive. You're going to get hit with a huge diagnosis very quickly, and then you're going to be told you need to pick between like 3 medications and you need to do it super, super fast. So it's going to be very overwhelming. But one thing that can help us is knowing what type of SMA your child is predicted to have. Type 1 is very severe, and type 4 is very mild. And so you can kind of figure out that if the child is predicted to have type 1, you need to move as fast as possible. And if the child is predicted to have type 4, then you can definitely take more time to think about things before you pick the treatment. And one thing I do want to note is that since one of the treatment options is gene therapy, and we're not sure which route we're going to go and treatment may be time sensitive, I'd say as soon as you know that you have this diagnosis, I would really close down your circle of contacts. Meaning with gene therapy, it's generally very safe. There are a few rare occurrences of some bad outcomes with children getting very, very sick after gene therapy. And most of the time that seems to happen if they have some sort of other illness around the time of getting gene therapy. So I always like to advise my families that really nobody should be coming to visit the baby or the child until you know which treatment you're going to take, because you really want to protect that child from any sort of infection while we're making arrangements for treatment. So the first treatment is Zolgensma gene therapy. It's eligible, children are eligible if they're anywhere from newborn to 2 years of age. They must have normal liver function, and they must not have any antibodies to AAV9, which is the package that the gene is put in. Another option is nusinersen or Spinraza, and this can be given to any type, any age of SMA, and so pretty much anyone can get it. You must have normal platelets. Platelets are your body's way of clotting your blood, and must have normal kidney function, and then the child must be able to get a lumbar puncture to receive the medicine. And then risdiplam is the newest option, and that's a medicine that's given by mouth. It can be given to any type of SMA, but the child has to be at least 2 months of age. So you can imagine if you are getting a diagnosis in a newborn and the thought is that the child would have type 1, we wouldn't necessarily want to wait 2 months before we start therapy. So my big takeaway points for spinal muscular atrophy are really knowing the type of predicted SMA that your child is expected to have if they're treated very early, or if they're diagnosed very early, and then schedule the treatment, pick your treatment and get it scheduled as fast as you can is really the best method for SMA. And then physical therapy is very, very important. You do need to be a little cautious though if your child is getting gene therapy, because again, I mentioned that we don't want the children to get any sort of infection around the time they've gotten gene therapy. So we usually give the family some recommendations for some like therapies they can do at home. And then once they're kind of completing the gene therapy course, then they can go into physical therapy. But if your child's going to be receiving nusinersen or Spinraza, or risdiplam, also known as Evrysdi, really physical therapy can start as quickly as possible. And then I also like to mention, and I probably could have put this in the general recommendation section, optimize nutrition and sleep. So your muscles and your nerves are going to work their best when they've been well rested and when they've been well nourished. And so that's really important to just ensure that your child can achieve their best functional outcomes. Next, we're going to talk about Duchenne muscular dystrophy. And so this is due to a mutation on the X chromosome, where this mutation makes it so the child cannot make enough of the dystrophin protein. And really what the dystrophin protein does is it helps keep the muscles strong and stable. And so if you don't have enough dystrophin, those muscles are going to break down a little more easily than somebody else's muscles. So this kind of accumulates over time, and the muscles continue to break down over time, and unfortunately, they can't be rebuilt. But thankfully, we do have some treatments that can slow the muscle breakdown. And we're also working on treatments that are aimed to make the genetic problem less severe. And you might have heard about those earlier today. So one important thing to know for Duchenne muscular dystrophy is what mutation your child has. We have some medications that are approved that are mutation specific. And so it'd be first and foremost important to know what mutation is causing the muscular dystrophy. And then once you know that, you can know if your child's eligible for any of the gene-specific treatments. The exon dys 51 is for skipping exon 51, bion dys 53 is for skipping exon 53, etc. But regardless, we have a treatment that is available to all boys with Duchenne, regardless of what gene mutation they have, and that's prednisone or deflazacort. And these aren't without side effects, especially if they're given daily. However, we like, at least at Nationwide Children's, to give the medications only twice per week. We feel like that really significantly reduces the side effects and still gives the benefit of delaying or slowing the muscle breakdown. And I'd really say that I start to get worried if I have a patient who's not on either of these by age 3. But we do sometimes start it even earlier, and there are some publications out there where it's been started as early as infancy. So I like to think about prednisone or deflazacort as kind of a necessary medication, especially now that we have lots of great treatments on the horizon that are looking at kind of correcting the gene problem or making the gene problem less severe. The thought is that if you can get your children on prednisone or deflazacort as early as possible, you're going to preserve as much muscle as possible, so they will have more muscle available if and when these genetic therapies do become approved. And then who knows, we'll see. The hope is that if eventually, if these gene therapies are approved, that maybe the children won't need to continue on the prednisone or deflazacort. But that's something that's still being studied and not for certain yet. And then of course, like I mentioned for SMA, optimize nutrition and sleep. So one other important thing for Duchenne muscular dystrophy is that it's not only needed in the muscles, but it's also a protein that's needed in the brain. So not every child with Duchenne will have problems with dystrophin in the brain, but some will. And so I think it's better to be proactive than reactive. And so I would suggest that any child that's been diagnosed, if they're very young, should go into like Help Me Grow or early intervention. Neuropsychological evaluations, which is very formal testing for how the brain learns and thinks, can be helpful. Usually we start those around age 3. Any sort of behavioral assessment can be helpful as well. That can start with a pediatrician. Is there anything in terms of concerns with attention or focus or anxiety? Anything like that would be important to identify early as well. And then typically we don't recommend physical therapy because if you push the muscles too hard, they'll break down faster, and so that may make the disease worse. Next, I'm going to talk about Charcot-Marie-Tooth disease. So this is caused by many different mutations, and so I won't get into specifics of that. But the most common genetic mutation results in a problem with the myelin that protects the sensory and motor nerves. And so it's really like an insulated wire that travels through the body to help with movement of the muscles and also to help with sensation. But because these nerves don't have the protective outer coating, they tend to degenerate over time. This, unfortunately, we don't have any significant treatments for. It's largely supportive, but actually there are some gene and genetic therapies that are being studied and may be coming down the horizon pretty soon. So really for Charcot-Marie-Tooth disease, we recommend therapies. So physical therapy is very important. Occupational therapy can be very important. Typically, it does not affect the chewing and swallowing muscles, but on occasion it can. So if that were the case, then we would throw in speech therapy as well. We also just like to make sure that you are very mindful about what medications you're on. Some medications can injure the nerves. You would want to avoid those. And then also I always like to ensure that vitamin D levels are adequate and also vitamin B12. And then again, optimize nutrition and sleep. Next, I'm going to talk about congenital myopathy. So this is another broad category of muscle disease. Many, many different mutations can cause problems with how the muscles develop or are formed in utero. But typically this is a problem while the baby is forming. So usually the muscles are most weak shortly after the child's born or around the time of birth. And then with the congenital myopathy, because it's a problem with how the muscle was formed, in general, there's usually the ability for stabilization or improvement over time. There are rare instances where things could get worse, but more often than not, symptoms seem to be worse at the time of birth, and then with therapies and interventions can slowly get better over time. And some of these do have heart involvement as well. And I forgot to mention, I'm sorry, for Duchenne, that the heart's important as well. So the recommendations for congenital myopathies are therapies, definitely physical therapy to help with movement, occupational therapy to help with activities of daily living, speech therapy because sometimes the muscles that for chewing and swallowing are affected, and also subsequently speech development can be affected if those muscles are weak, and then also optimizing nutrition and sleep. And then the last condition that I'm going to talk about today is a very complicated one because I think of it as more of a whole body problem, meaning that this is congenital or myotonic dystrophy, and it's caused by a mutation, interestingly, where it causes the gene to have extra DNA. And just the presence of this extra DNA can be toxic to a lot of body systems. It can be toxic to the muscles, it can be toxic to the brain, it can be toxic to the endocrine system. And so it's more of a widespread disease than some of the other conditions we talked about. Usually with the congenital onset, that means at the time of birth, these children are very, very weak. And so they don't experience some of the stiffening that can be seen in patients that have onset older. This extra DNA, this toxic extra DNA can either make the muscles very, very weak if it's a problem in the children around the time of birth, or it can be a problem with the strengthening and relaxing of the muscles later on in life. And as I mentioned, it can be systemic. It's another one where problems can happen with the heart. And unfortunately, also, this is another one where treatment is largely supportive and preventative. But again, people I know of are working on specific treatments for hope. So hopefully we'll have something important in terms of treatment in this in the future. So again, physical therapy and occupational therapy are very important. This can help prevent contractures, which is where when the muscles become so weak, the limbs become kind of fixed in the position. And also therapies can help the patients learn techniques to help the muscles relax, to help make the stiffness less severe. When the child is very significantly affected early on, speech can be difficult, but also swallowing can be difficult. And then this is kind of a more whole body disease, so it's important to have monitoring for any eye problems, any ear problems, any endocrine problems. So again, seeing the regular pediatrician or family doctor is very important. And again, optimizing nutrition, but also the gut can be involved, so monitoring closely for any GI problems as well. And then this, I believe, is my last slide. So this is another one where this is the same condition, but it's another one where the brain can be involved, like we talked about with Duchenne muscular dystrophy. And this is actually probably more likely to have brain involvement for every child versus Duchenne, where it's not necessarily every child. So I very much stress the importance of early intervention, help me grow, anything like that. Definitely neuropsychological testing by age 3. Certainly going to need IEPs or individualized education plans for school, and more likely to have mood and behavioral issues. So definitely focusing on any behavioral concerns or anything that may be slightly off very early on, getting that taken care of earlier rather than later will be important. And then interestingly, in this condition, sleepiness during the day is very significant. And so it's very hard for the children to stay awake, even if it seems like they get a good night's sleep. So it's very important to talk to your MDA doctors about that so we can help alleviate that as much as possible. And then because of the mention of endocrine problems, sometimes getting regular routine blood work is very important in this condition as well. So I don't know how I did on time, hopefully not too far over. Let me know
No, you did great.
Okay.
I was just curious on the conditions that you said and recommended physical therapy, occupational therapy. How long of a stint would you recommend? Are you talking a couple months? Are you talking all year long? What is a kind of a general guideline for physical therapy?
Yeah, so that can be difficult.
Okay.
For example, for spinal muscular atrophy, if you have a child who's diagnosed very early, let's say off of newborn screening, and you get your child treated very early and start therapies relatively soon, you may only need to do it for a few months to maybe a year. If you have a child who is more affected or has some weakness at the time of treatment, that may need to continue for a little bit longer. But we can also have the therapist do some education of the patient and the caregivers. And so there are some exercises that could be done at home, so you don't have to be traveling for therapy sessions all the time.
Okay.
Usually it's more intensive in the beginning, and then you can space it out over time. And sometimes if no progress has been made for many sessions, then you may discontinue at that time. It's hard. It's a very individualized plan.
And you stated on your PowerPoint that physical therapy wasn't recommended for Duchenne boys, but stretching is, correct?
Yes, yes.
Okay.
Sorry if I didn't make that more clear. I probably went too fast through some of my
I just
slides.
wanted to make sure.
So, and to be honest, sometimes very early on in our Duchenne boys, they do have physical therapy, right? So they're maybe delayed in walking and they go to a physical therapist, and then they help them achieve the skill of walking or jumping. And then kind of once they've reached their appropriate developmental milestones, that's the point where you would probably stop going to therapy because you don't want to push the muscles too hard. You can certainly see a physical therapist for helping to prevent contractures, so doing stretching, things like that. Sometimes we do aqua therapy to help with range of motion, but I think I probably should have put on the slide no physical therapy with the hopes of like gaining muscle or gaining skills.
Okay. I don't see anything else that has popped up. So thank you very much for your presentation and your time today.
All right, thank you for having me.